20 PANCE Practice Questions of Fibrillation with Answers and Explanations Part 2. Hello, welcome to the Science Guide ASAP Learning. Today, we are going to be practicing 20 PANCE style questions. Hope this helps. Please support this new channel by liking this video and subscribing for more videos like this one. Question 11. Which of the following is not a risk factor for developing atrial fibrillation, AFib? A. Age over 60 years. B. Hypertension. C. Diabetes. D. Low levels of physical activity. Answer. D. Low levels of physical activity may be associated with other cardiovascular risk factors, but it is not considered a direct risk factor for developing AFib. Age over 60 years, hypertension, and diabetes are all known risk factors for AFib. Question 12. A 75-year-old male with a history of hypertension, diabetes, and heart failure presents to the emergency department with palpitations, shortness of breath, and chest discomfort. ECG shows an irregular rhythm with absent P waves and a rapid ventricular response. Which of the following is the most appropriate initial treatment? A. Digoxin. B. Amiodarone. C. Diltiazem. D. Cardioversion. E. Aspirin. Answer. C. Diltiazem. The patient's presentation is consistent with atrial fibrillation with rapid ventricular response. The initial management of symptomatic AFib with rapid ventricular response includes rate control with medications such as diltiazem, beta blockers, or digoxin. Amiodarone and cardioversion are options for rhythm control in patients who fail rate control, while aspirin is not the first-line therapy for AFib. Question 13. A 68-year-old female with a history of AFib on warfarin presents to the clinic for a routine follow-up. Her INR is within the therapeutic range, and she reports occasional palpitations but is otherwise asymptomatic. Which of the following is the most appropriate management strategy for this patient? A. Continue warfarin therapy. B. Switch to a direct oral anticoagulant, DOAC. C. Discontinue anticoagulation. D. Perform electrical cardioversion. E. Initiate rate control with beta blockers. Answer. A. Continue warfarin therapy. This patient with a history of AFib and no symptoms should continue anticoagulation with warfarin or a DOAC to reduce the risk of stroke or thromboembolic events. Electrical cardioversion is reserved for patients with persistent AFib, while rate control with medications such as beta blockers is appropriate for symptomatic patients. Question 14. A 50-year-old male with a history of paroxysmal AFib is started on dofetilide for rhythm control. Which of the following is the most important monitoring parameter when starting this medication? A. Blood pressure. B. Potassium levels. C. Liver function tests. D. Renal function tests. E. Serum electrolytes. Answer. D. Renal function tests. Dofetilide is a class 3 antiarrhythmic medication that is effective for maintaining sinus rhythm in patients with paroxysmal AFib. However, it is primarily eliminated by the kidneys and can cause significant QT prolongation and potentially fatal ventricular arrhythmias in patients with renal impairment. Therefore, monitoring renal function and adjusting the dose accordingly is critical in patients taking dofetilide. Question 15. A 60-year-old female with a history of AFib presents to the clinic for a routine follow-up. She reports occasional palpitations but is otherwise asymptomatic. ECG shows a persistent AFib, and her CHA2DS2 VASC score is 1. Which of the following is the most appropriate management strategy for this patient? A. Initiate rate control with beta blockers. B. Initiate anticoagulation with warfarin or a DOAC. Perform electrical cardioversion. D. Initiate rhythm control with amiodarone. E. No specific treatment is necessary. Answer. B. Initiate anticoagulation with warfarin or a DOAC. This patient with a persistent AFib and a CHA2DS2 VASC score of 1 should be started on anticoagulation with warfarin or a DOAC. Question 16. A 67-year-old male presents to the emergency department with chest discomfort, palpitations, and shortness of breath. He has a past medical history of hypertension and hyperlipidemia. His ECG shows an irregular rhythm with absence of P waves and QRS complexes of varying duration. Which of the following is the most appropriate next step in management? A. Immediate cardioversion. B. Administer amiodarone. C. Administer heparin and admit to hospital for further evaluation. D. Administer aspirin and refer to outpatient cardiology clinic. Answer. C. Administer heparin and admit to hospital for further evaluation. Explanation. The patient presents with classic symptoms of atrial fibrillation and his ECG confirms the diagnosis. Immediate cardioversion is not indicated in all cases of AFib and is reserved for patients with unstable hemodynamics or severe symptoms. Amiodarone can be used to help maintain sinus rhythm, but the patient requires anticoagulation prior to any rhythm management strategy. Heparin should be initiated for anticoagulation and the patient should be admitted for further evaluation. Question 17. A 52-year-old female with a history of AFib presents to the primary care clinic for routine follow-up. She is currently taking warfarin for anticoagulation and metoprolol for rate control. Which of the following is the most appropriate next step in management? A. Refer to cardiology for consideration of rhythm control. B. Increase metoprolol dosage for better rate control. C. Initiate a direct oral anticoagulant, DOAC, in place of warfarin. D. Discontinue anticoagulation therapy. Answer. C. Initiate a direct oral anticoagulant, DOAC, in place of warfarin. Explanation. This patient is being treated for both rate control and anticoagulation, which are the two main components of managing AFib. Warfarin has been the traditional choice for anticoagulation, but DOACs have been shown to have similar efficacy and safety profiles with less need for monitoring. Metoprolol is a beta blocker used for rate control, but increasing the dosage may not be appropriate for this patient. Referral to cardiology for consideration of rhythm control may be indicated in certain cases, but is not the most appropriate next step in this patient's management. Discontinuing anticoagulation therapy would be inappropriate and puts the patient at risk for thromboembolic events. Question 18. A 75-year-old male with a history of hypertension, diabetes, and AFib presents to the emergency department with weakness and slurred speech. His vital signs are within normal limits and his ECG shows atrial fibrillation. A non-contrast head CT scan is negative for hemorrhage. Which of the following is the most appropriate next step in management? A. Administer tissue plasminogen activator, TPA. B. Initiate heparin and admit to hospital for further evaluation. C. Discharge home with aspirin and refer to outpatient neurology. D. Administer intravenous magnesium sulfate. Answer. B. Initiate heparin and admit to hospital for further evaluation. Explanation. This patient presents with classic symptoms of stroke, which is a common complication of AFib. Immediate administration of TPA is contraindicated due to the patient's recent history of atrial fibrillation. Heparin should be initiated for anticoagulation to prevent further thromboembolic events. Question 19. A 68-year-old female presents with palpitations, shortness of breath, and dizziness. On exam, a regularly irregular heart rate is noted. EKG shows fibrillatory waves with no discernible P waves. What is the most appropriate initial treatment for this patient? A. intravenous adenosine; B, intravenous diltiazem; C, intravenous amiodarone; D, electrical cardioversion. Answer: B, intravenous diltiazem. This patient has symptoms of AFib with a rapid ventricular rate. The first-line treatment for stable AFib with rapid ventricular response is rate control with medications such as beta blockers, calcium channel blockers, or digoxin. Diltiazem is a calcium channel blocker that slows the heart rate and is preferred in patients with underlying systolic dysfunction. Adenosine is used to terminate supraventricular tachycardias, but it is not effective in AFib. Amiodarone can be used for rhythm control, but it is not the first-line treatment in this scenario. Electrical cardioversion is reserved for unstable patients or those who fail medical management. Question 20. A 54-year-old male with a history of hypertension and AFib presents to the emergency department with chest pain and shortness of breath. He is found to be in AFib with rapid ventricular response. EKG shows street segment elevation in leads 2, 3, and AVF. What is the most appropriate next step in management? A. Start intravenous heparin and consult for urgent catheterization. B. Start intravenous nitroglycerin and consult for urgent catheterization. C. Start intravenous amiodarone and consult for urgent catheterization. D. Start intravenous metoprolol and observe for resolution of symptoms. Answer: A. Start intravenous heparin and consult for urgent catheterization. This patient has AFib with rapid ventricular response and ST segment elevation in leads 2, 3, and AVF, suggestive of inferior wall myocardial infarction. The most appropriate next step is to start anticoagulation with intravenous heparin and consult for urgent catheterization. Nitroglycerin can be used for symptom relief in patients with myocardial infarction, but it is not the first-line treatment. Amiodarone can be used for rate or rhythm control in AFib, but it is not indicated in this scenario. Metoprolol can be used for rate control in AFib, but it should be avoided in patients with acute myocardial infarction. Please like this video, subscribe for more videos like this, and comment for more suggestions. Thank you for watching.